I would deal with clients who had been readmitted to the hospital 20 or 30 times. Usually they had 20 or 30 different diagnoses.
My clients being told that they've got a chemical imbalance in their brain and that they need to have medications for the rest of their lives.
We know that stimulant medications have a risk of sudden cardiac death, and we know that they cause decreased height, decreased weight in kids.
That's who is the drug dealer now, and that's where most of our addicts are coming out of, is the doctor's offices, not the street corner.
We know from the research if people go in the hospital and we just do psychosocial treatment, or not even any treatment, eventually the psychosis will go away.
When they look at long-term outcomes for ADHD, for those medicated, they'll see no benefit on any domain of functioning long-term.
A lot of people hear or are told by their physicians or hear in the news or in implied or explicitly or implicitly in ads for drugs that their problem that makes them eat too much or too little, sleep too much or too little, be too happy or too sad is caused by a chemical imbalance. At best, this idea is like a hypothesis. It's a guess at best. It's an educated guess at best.
I've been working with clients to help them reduce and avoid medications and the effects of the labels and diagnoses that people in psychological distress labor under for over 10 years. And most every client I've ever been with has come into my office having been told they have a permanent genetic and biological defect in their brain.
I've had many patients tell me that they have been told that they have a chemical imbalance that is causing their depression or some other mental health issue that they're struggling with. And what I can tell you, at least in the terms of depression, that there's never been any consistent evidence that shows anybody with depression has a chemical imbalance that is causing their depression.
Well, there's a common misperception out there that you have a chemical imbalance in your brain, i.e., that you're missing some type of dopamine or serotonin or norepinephrine, when in reality, any one of the people watching this can ask their physician to check the dopamine in their brain tomorrow afternoon in an appointment, or their norepinephrine. And the fact of the matter is, we can't check for your dopamine levels in your brain. It's not possible. So it's just a hypothesis that this is creating all these behaviors. And the fact of the matter is, it's non-scientific because there's no possibility that we can assess your dopamine in your brain.
If somebody is told at the beginning of their illness, or say an initial break, or maybe their second breakdown, that there's no hope of recovery and they've got some deficiency in their brain, that's just devastating. And it's not true. That's really the horrendous thing about that, is that it's not true.
There have been attempts to find, for example, neurotransmitters that are low, like serotonin, but there's no evidence that depressed patients have lower serotonin levels. And there's no evidence that any of the medicines we call antidepressants correct any chemical imbalance. And if anything, most of the evidence suggests that they can cause some side effects, some of which are serious or adverse events. So one could argue that they may actually, in some cases, be causing a chemical imbalance. We know at the neurotransmitter level, for example, the receptors for serotonin decrease in number when someone has an antidepressant in their body, because The nerves can't handle that extra influx of the chemical, so then the nerve endings have to make an adjustment and down-regulate the number of receptors. So far from a chemical imbalance causing depression, I think there's more evidence that these medications that we're calling antidepressants can cause a chemical imbalance.
Sometimes people come to me and they'll say that they have a daughter or a son, 11 years old, 10 years old or so, and they'll go on to medications for ADHD or a behavioral problem. And as they start to get older, the medications keep changing. And they're told exactly that because their bodies are changing and their chemical imbalance is changing, they have to adjust with the medications. It is true, bodies go through a huge amount of changes through adolescence. If there's a true hormonal imbalance, that can be measured. It's verifiable, and they treat it as a hormonal imbalance. There's no such thing as a chemical imbalance in the brain.
But really, it's just a seductive kind of slogan to make you take a drug, to give you a very simplistic explanation about what your problem is. And when you market drugs, you need a very simple message that you hammer over and over and over again. So the chemical imbalance notion, again, is a marketing slogan that sells an idea that you need to be able to tell yourself, to justify to yourself and others, that's why I'm taking this drug. And it kind of vaguely sounds medical, because it's got the word chemical. And imbalance, well, I mean, imbalance you can easily relate to. Well, imbalanced, I'm disordered, unbalanced, destabilized. I mean, it's just it's a metaphor. It's a verbal picture. But what it means to you is not what it means to me. And that's where the strength of it lies, is that no one ever has to define it. No one ever has to say, that's exactly the concrete referent of that metaphor. Because, as soon as you hear the word, you know, well, that's what it means to me. Now it means something completely different to me, but we don't never have to worry about that because the word just ends the discussion and stops the thinking.
They put me on all kinds of different medication for a while, and none of them really seemed to help too much. A lot of side effects. I was on disopramine, Zoloft, Risperdal. Lately I was on Abilify, Seroquel. And they put me on Effexor, which I'm taking right now, and I haven't really had any problems with that. Another one that I was on was Cogentin too, which supposedly was supposed to help with some of the side effects.
The medications I'm taking, I have to look at bottles, are Trazodone, which helps me sleep at night. I take it along with Alaprazam, which is a generic for Xanax. I take 2 a day. I'm supposed to take 3, but I'm not. And then I take two pills. It's actually 1 pill, but it's 2 different strengths of the sertraline, which is really for epilepsy, and it has side effects that help depression. And I take a pill called Abilify, which lifts you up, and I take a small amount of that every day. I tried to get off it, and my doctor said, it really helps you. Anyway, whenever I try to get off of any of my drugs, he says, "You feeling okay?" "Yeah." "Let's leave it that way." I'm like anxious to get off some of my drugs because it just bothers me that I have to take them.
I was told that it was a chemical imbalance. Something wrong with my brain, wasn't working right. My symptoms are major depressions. I've been suicidal in the past. I've had a lot of side effects with medications. I was told in the beginning that I would probably never get better, that I couldn't work, and had to be on medication for the rest of my life.
My diagnosis is chemistry imbalance. And I'm not bipolar, but I'm borderline. I was so depressed at one time that I thought about killing myself, and that's when I started going to the psychiatrist I've been going to for 7 years. And that thought came out of my mind. It's gone.
People have talked to me about chemical imbalance, and my psychiatrist was one of those, and was trying to explain that to me, that there was an imbalance of serotonin in my brain. My interpretation of a chemical imbalance is a lack of serotonin functioning in the brain. And when you have to get that straightened out, the antidepressants do that.
I had a therapist sit down, look me straight in the eye, and tell me, you will be in mental institutions until you are dead, most likely. And she had there was no joke in her eye. There was no sense of hope or sense of, come on, beat me at this.
I had a mom who ended up in an inpatient facility, and when she was released from the inpatient facility after 4 weeks, she was on 12 psychotropic medications. So when she came to me, she was catatonic. That's not helpful.
I was a psychiatric social worker for a time. I would deal with clients who had been readmitted to the hospital 20 or 30 times. Usually they had 20 or 30 different diagnoses. It's no different if you're dealing with children or adults. So that's a really important problem that we have not solved, that we don't think DSM-5 is going to solve. Actually, there's a little sign that it's going to improve. And so this is always looming out there as a problem, because ostensibly different diagnoses mean different treatments and different trajectories and different outcomes, and yet we see massive disagreement about what the person actually suffers from. And that's just a fundamental problem that we haven't solved yet. And until we do, we're going to have a hard time having a scientific psychiatry.
Over the past 10 years, I've been in treatment in mental health here in LA. And I didn't even know what my diagnosis was until this year when I applied for my Social Security. And then Social Security got the records from mental health, and the Social Security guy, he told me that they had diagnosed me as bipolar.
Some of the diagnoses that I was given by multiple psychiatrists and psychologists were bipolar disorder, which I was diagnosed with too young, under the age of 10, and so it was taken off by the time I was 15. The doctor that actually took that off of me said that I'm a damn good actress and I'm a pain in the ass, but I'm not bipolar. The end result of all the different diagnoses, defiance disorders, multiple different personalities disorders, and so I had the psychological and I also had the behavioral. The main one that has stuck so far that I have multiple traits of is borderline personality disorder.
First of all, we have to talk about how these diseases get into the DSM in the first place, and they're voted on by the American Psychiatric Association. It's very interesting to note that we don't vote on diabetes or heart disease because there's markers that indicate that we have a disease. But with diseases such as ADHD or depression or anxiety, they're voted into the DSM. And interestingly enough, homosexuality was a verifiable disease until 1978 in the DSM, and then they voted it out. So these types of diseases you can vote in and out.
People don't realize that psychiatric diagnoses are not regulated by anybody. So that means any professional can give you any label and not have to try to protect you from the kinds of harmful consequences of just getting a label. I'm not even talking about drugs here. I'm talking about just getting a label. So people have lost jobs. They've lost their health insurance because now they have a pre-existing condition, or their premiums skyrocketed. They've lost custody of their children for having what you might think would be among the least harmful diagnoses. They've lost the right to make decisions about their medical and legal affairs.
They give me a new shrink this year. And then at the last appointment I saw him at in October, we were discussing the issue. And then the guy finally says, "Oh, you have a traumatic brain injury." I'm like, "What the hell do you think these scars mean, dude?" "Yeah." "Oh, you got that." I was like, "Yeah, and y'all got me as bipolar." And when I said that, I couldn't believe what these people told me. They said, "Well, don't worry about that. You stay with a bipolar because you can get your Social Security easier being bipolar than as PTSD." And I'm like, "But I'm not bipolar."
I mean, we're dynamic human beings. There's so much that goes into an individual. And so oftentimes we jump quickly to a mental illness diagnosis when actually it is a natural reaction to a trauma event. Now, that's not how it is all the time, but again, we need to be in dialogue with each other and have human conversations.
The first time I experienced depression was 18 when my dog died, and the second time I experienced it was 25 when a girlfriend left me. Relationship had ended, and it was mourning, a lot of sadness, and that just was continuing on and on and on, and it was going on 2 years. And the feelings of mourning and sadness were turning into suicidal feelings. And it got to the point where I either had to just do nothing and continue this way, or end it, or try to take some action to see a psychiatrist.
In 2007, I was diagnosed with multiple sclerosis. With multiple sclerosis came many medications for different symptoms. One of the symptoms I was having was pseudobulbar. It's the weirdest thing in the world. And when I first went to the doctor with it, I said, I'm like laughing for no reason. I could be sitting in a meeting, a professional meeting, and suddenly start laughing, and I don't know why. And she said, "You're depressed. You need medication." I said, "I'm not depressed, I'm laughing." And because that's how it presented itself in the beginning, was uncontrollable laughing. And it eventually turned into the crying for no reason or whatever. So it wasn't until I was diagnosed with MS that we knew what it really was. And it's not depression at all. And it's not a mood problem. Yet they medicated me for a mood problem. So I was clearly over-medicated, but they didn't know how to deal with it any other way.
In the institutions that I attended, or the residential treatment centers, some of them were good. The therapists were genuine, and the staff were there for something other than the penny that they earned an hour. But there were other people there who repeatedly would tell you, "You're going to be in mental institutions for the rest of your life. You're a fuck up. Your parents don't want you. They gave you to us because they didn't know what else to do with you.
I was taking Xanax, and I don't like to be on drugs. At the point where my father dies, it was a breaking point for me. So I decided to stop taking all at once, the sleeping pills and the antidepressants. And I started taking my vitamins. And it helps me and I think it's because I was decided to, to do it. Is the power is within you. If you really want to solve the problem, you have to find your power. Otherwise, you're going to be always dependent on the medications, and that's it's a great business for the pharmacy, for the laboratories, the doctors. Yeah, it's convenient for them, for you to be sick forever and taking your pills forever, but it's not convenient for you.
I was on extremely high dosages of Prozac, Zoloft, and everything like that. Any possible antidepressant, antipsychotic that they could possibly find for me. Well, during all the times since I've been on medication, it's many years. I've always been on medication. And so all I could think about was how stable it made me feel or how dependent I had to be on those medications. Everybody, therapists, my parents, my family, everybody telling me that medication would make me better, it would fix me. In residential treatment, they like to play with medication. They like to see what works best. And sometimes seeing what works best goes at the expense of the mental stability and the emotional stability of what we have.
Working in psychiatry, particularly with adolescents, I would advocate for medications to be reevaluated because I wasn't sure they were making any difference, and we would just keep people on the antidepressants. And I would make sure that these kids knew not to stop them abruptly because of what can happen. And I think that may explain why you hear of Prozac leading to suicide, because what kid takes medicine every day? If it wasn't working, they'd switch them to another antidepressant. If that wasn't working, they might add an antipsychotic or a mood stabilizer. And if that wasn't working, they'd try something else. And I know from personal experience that you can experience more depression after you taper off of as you taper off of an antidepressant from the withdrawal, and that it's a very legitimate thing. And when I raised that, in particular to the physician I was working with teenagers, he said there was no research or real evidence.
And you also have to wonder about taking the brain of a young child and starting to expose them to one of these medications, possibly when they're a year or 2 years old, or even if they're 5 years old, they could potentially be on that medication for the rest of their life. And what that medication does to the brain as it goes through childhood and adolescence is really unknown. Most of the studies that have been done are very short term, 6 weeks, 8 weeks. There's a couple of longer studies, but even those aren't very long, 18 months maybe. And what the effect of them long term is really a big question. There's very little data on the effectiveness of any of these drugs long term in adults or children.
I take 200 milligrams of Seroquel a day, which is the bipolar medication, and I take 100 milligrams of Prozac. The reason I'm going to stay on that medication is because once you come off of Seroquel, you don't sleep, period. And I've stayed awake for 9 days with no medication and no illegal drugs or anything. Just stayed awake. And then, of course, at that point, you're getting psychotic. So I have to stay on the Seroquel now.
We've got millions and millions of American boys right now diagnosed with ADHD on full-time methylphenidate, a dangerous and addictive drug. It's in the same classification as methamphetamines. These are class 2 stimulant drugs. These are highly dangerous and addictive drugs.
When you work special ed, the percentage that you see that are ADHD kids is probably a good 20 to 30% are ADHD, if not more.
When I was diagnosed with being ADD would have been end of 2nd grade going into 3rd. Parents did quite a bit of testing. I remember going to see a psychologist, and then we found out and was put on medication.
Let's talk about ADHD, which is an area that I know well. The significant percentage of my patients come in with that complaint of ADHD. Well, we know there's a ton of evidence that in the short run, 6 weeks, stimulant medications have a very sizable effect size in treating these behaviors. And the effect size may be 1.2, 1.4. It's a considerable, these are strong, potent medications. There's no doubt. You put a child who's hyperactive on stimulant medications, they will significantly improve. But when you look at the long-term data with stimulant medications, whether this is the RAIN data out of Australia or the Oregon study or most importantly, the MTA study, which is the largest, most important study of ADHD in child psychiatry ever done. And the 8-year follow-up study, which was published a couple years ago, showed that there's no evidence that treatment with stimulant medications improve the long-term outcome of these kids in any functional capacity. And the data just keeps stacking up. And we know that stimulant medications have a risk of sudden cardiac death, and we know that they cause decreased height, decreased weight in kids, and a lot of physical morbidity as well. So this is not an insignificant treatment. This is not a benign treatment.
When you talk about medication, it's kind of the whole gamut of this medicine works, this medicine doesn't work. I don't want my kid on drugs. And the bottom line is that you can't put a kid on medication and just think that's the cure. You have to do constant medication monitoring. I've had parents tell me that their student has had horrible, horrible side effects with an ADHD medication, and then they don't want to put their kid on a medication. You know, they don't want to try it, but they haven't been able to work that out with their doctor, where they're trying either a different medication or a different dosage or a different combination of medications.
I have a German Shepherd puppy right now who's 6 months old, and I was looking at the DSM criteria for ADHD, and he fits every single one of the characteristics. Now, does he have a brain disorder? No, he doesn't. He's a young male, unneutered. Lots of testosterone and androgen are flowing right now in his little adolescent body, and he's very naughty. So, of course, we could drug Heinrich. That's my old German Shepherd's name. But the fact of the matter is, what he needs is a lot of discipline, lots of love, lots and lots of exercise, and he's going to outgrow this. He won't always act like this, nor will any other young mammal. Now, I can drug Heinrich. I can make him very sedentary, quiet, take away that spontaneity, take away his refusal to sit quietly, but then I don't have Heinrich anymore. That's part of who he is. That's what young mammals do. They're inattentive. They don't pay attention to the boring and the mundane. They're highly active. They run, jump, and climb. They do all manner of things that drive adults crazy. It's always existed. It exists across cultures, across mammals, and across time.
Part of the problem with diagnosing ADHD is schools are not medical doctors. We don't diagnose ADHD, but what we do is identify behaviors that affect them educationally. I have a student I worked with last year, and parents were anti-medication, but he was so successful because Mom was making sure that he had the homework done. She had good communication with the teacher at school. The teacher was able to tap into the student's strengths and get him to perform well academically at school. I think there are cases when you can do well without medication, but it's a lot of work.
That term ADHD, that attention deficit hyperactivity disorder, okay, it's just pretty normal. Most people don't even understand if they have it to some degree or not. You know, you can have an ADHD moment without even knowing it. It's a behavioral science kind of thingy. You know, it was around 2010 when I received the official diagnosis, and I thought, okay, I'll try it. So I did, and I was put on Wellbutrin the first time. I didn't like it. I guess I didn't like the changes in my body, physically and psychologically. I didn't like those. Now with Statira, I didn't really have any problems with it. No, I think I took it for about 3 months. But like I said, with treatment, and some people with medications are able to deal with their behavior and catch themselves. See, treatment taught me how to catch myself.
We do know this, that for as long as kids have been around, there's been kids that have sort of bounced off the walls, okay? And that's forever. And go read, Huckleberry Finn and Mark Twain and stuff. And what we also know is that the the child of 5 is not the adult of 25. And the other thing you can see is graduate from high school and go back to your reunion 20 years later. And the people who were sort of screw-offs half the time, you know, they own businesses or they're doing great things. And sometimes the people who excelled in school are sort of stuck in jobs.
My experience with depression is a sense of feeling overwhelmed, that I just couldn't feel in control of all the stress around me, that I felt overwhelmed is the best word I can use, and just incapable of being happy and not taking joy in things. And I was functional, I always worked, and people wouldn't necessarily know I was depressed, but I felt depressed, that really it was so overwhelming. There was no way I could overcome these things, and just a lack of joy in life.
Depression always ends, not just because of Prozac and not just because of a good therapist. Depression always ends because it is in the very nature of depression to end.
I didn't find out I was that I suffered from depression until I got to be an adult and I understood what depression was, because I thought it was pretty normal and, you know, not perfect, but, you know, through my treatment for ADHD and looking back on my upbringing and my childhood, now I understood why I was in such a behavioral pattern. I got over my depression as an adult, basically with treatment. Treatment that included some medications, counseling, other alternative activities related to treatment, such as acupuncture, meditation, things like that.
Well, you go back and here's what you read in 1965. Depression will get better. It's self-limiting. We need to use the drugs to help speed that up. But you're going to get better. That's number one. And how about its long-term course? Depression is an episodic illness, and very few people become chronic. It's seen as episodic. It's seen as something that hits you for a time and then generally goes away. If you look at first episode depressed patients, hospitalized for depression, okay? Out of that first episode cohort, maybe 20% would end up chronically ill. The other 80% would have an episode, and maybe 3 years later they'd have another episode, but it was an episodic illness. Manic depressive illness, same thing. Seen as an episodic illness, and in 1969, the leading manic depressive expert in the country said, listen, the one thing we can tell parents is it's not likely to be chronic.
I have a woman who came to me 16 years after the death of her baby, and she'd been on psychotropic medication for 13 of those 16 years. And when she came off the psychotropic medications, she felt like she had a crash. And really all she needed to do was, she just needed someone to tell her that her pain was okay. She'd hidden the pain for so long. She'd unnamed it, and she'd masked it, and she'd suppressed it for so long that it stole from her ability to feel joy. And so did she technically have depressive symptoms? Yes. She didn't before her baby died, but she did after her baby died.
A lot of depression is behavioral, and you don't realize how there are things that you should avoid doing when you're depressed. You should avoid talking in a weak, sad voice. You should not take to your bed. You should not close all the blinds and stay in darkness. And you should not avoid people. That's the time to go out, re-engage, look at the world, and so that you have new ideas and new thoughts that will be able to occur to you because you have decided to re-engage. So disengaging and going into the behavioral syndrome of depression, which often passes for depression. See, that's the thing, when you take your behavioral pattern of depression into the psychiatrist, your behavior and your idea of yourself is what gets diagnosed, not your brain.
in the late 60s, I was working in the mental hospitals. And, nobody was there for depression. And, in fact, it wasn't a word that was used very often. The people that were there were psychotic. And so I'm wondering how this epidemic of depression got started. And I'm in the camp where it's drug company propaganda. Now, even more surprising to me is the bipolar II label. And I think the world needs to know that prior to 1994, bipolar II did not exist. They put it in 1994, not without controversy. And when I worked at the state hospital, I saw in 8 years 3 people who were bipolar. Now, when I teach my psychopathology classes, I invariably have 3 students who announce that they're bipolar.
Young children on antipsychotics is a relatively new phenomenon. We have no idea the consequences of this, but it's really hard to fathom. We're supposed to be in an era of evidence-based medicine where we make treatment decisions based on evidence. It's very difficult to find compelling scientific evidence that disruptive children should receive medications that have been traditionally reserved for people diagnosed as psychotics, such as people diagnosed with schizophrenia. And we're seeing mounting concern about these issues, especially as a social worker. I'm concerned about in our foster care system. We have children who've been traumatized, have been through some really rough life circumstances, are acting out, but approaching it as a medical problem, diagnosing pediatric bipolar disorder and giving an antipsychotic, it just seems like a perversion of justice just in terms of treating our children fairly.
I was on Ritalin on a relatively low dose. It helped me focus, but the problem is I noticed 3.5, 4 years into taking it that I did not like being like a mindless zombie. Like I'd still be able to focus in class, but like at the time that recess or whatever, where I'm supposed to be active, I just want to sit there and do nothing.
In this book, I really looked at sort of the long-term outcomes with antipsychotics. I looked at them with antidepressants. I looked at them with mood stabilizers and anti-anxiety. And then I looked at stimulants for kids. It's when you compare naturalistic outcomes, people who get off treatment or never go on treatment, to those who go on the drugs and stay on the drug. The unmedicated group, long-term, always does better as far as I can tell. That's one comparison. You can also see what sort of outcomes did we used to see, say, for depression, bipolar, psychosis. What do we see today? Those epidemiological studies. All the epidemiological studies show outcomes worse today than they were 40 years ago. I know that's surprising, but you see this over and over again. And maybe the most surprising thing is actually in the literature, the leading experts in the field are raising red flags. They're going, why are our outcomes deteriorating so much? And they'll be saying, we think maybe it's the drugs. Maybe the drugs are causing this biological change in the brain that make people more psychotic over time, or make people more depressed over time, or make people more anxious over time.
The person sitting, drooling, catatonic, hearing voices, diagnosed as schizophrenic, is struggling in a human way just as anybody else. We commonly believe that the schizophrenic suffers from a disease that literally stops his life. It's not true.
Because I had the diagnosis of schizophrenia, I was told, I had to take these medications, that I needed to take them for the rest of my life, and also that I had a mental disorder that people never get well from.
Well, our story began when Catherine was 19, and by chance I met her at UCLA Hospital, where she had been brought by her mother because she had been suffering from schizophrenia for 2 years.
I was started on antipsychotic meds, and back then it was the older conventional antipsychotic medications, and the meds that I was started on were Thorazine, Stelazine, and I believe it was Artane, either that or Cogentin. And I remember that at first it kind of muted the voices a little bit. However, it made me feel kind of dead inside.
It made me feel very sedated. And so it didn't help at all with being withdrawn or isolating. I just did that all the much more. And then within, I'd say, about 6 months, 5 months, the voices came back louder than ever.
Catherine was admitted to UCLA Neuropsychiatric Institute, where I began to see her in psychotherapy. I did not use any medication in sitting with Catherine. I thought it would cloud her mind and cloud my understanding of what this was all about. I saw her 6 days a week for the entire 3 years she was hospitalized at UCLA. During the time that I saw her, in the beginning, she barely spoke, usually 1 or 2 words or 1 or 2 sentences. During the first year, all she would do would be to come in and sit down and bend her head down on her chest and scrunch her hands together in an expression of what could only be agony.
For almost a year, I didn't even speak. I just sat in a fetal position, rocking back and forth. Because for me, I needed to keep my internal psychotic environment. I needed to control it myself because I didn't have trust or faith that anybody else could.
She had been hearing voices to kill all members of her family, particularly her mother. She'd been on antipsychotic medication. She was not any better. I was also under great pressure to medicate her, but I did not. I persisted. We ended treatment at the end of just about 7+ years. Catherine has been a professional psychiatric nurse for 32 years. She's been in charge of an indigent population out in Palm Springs, California. Catherine then retired and now is a clinical instructor at a nursing school. So this business of symptomatic recovery, or this business of just being able to function at a low level, is not at all necessarily so. Catherine's fully functional. She lives a rich life. Many years after she got better, she approached me about writing a book. So indeed, we did write a book called Dante's Cure, A Journey Out of Madness, which details her treatment and recovery.
So if you look back from 1945 to 1955, the decade before Thorazine comes in, and you look at first episode schizophrenia patients, these people are hospitalized. Now, common wisdom would be they go in the hospital and they don't come out, right? Because you can't come out until you get Thorazine. That's absolutely not true. If you follow first episode cohorts, 70% would be out in about 12 to 18 months. And 5 years later, somewhere between 65 and 75% would be living independently in the community. They would be working. Many would be married. So what happened was, think about that. We go to first episode cohort, 70% actually are back out 5 years later working and living pretty independently. That meant 30% of that initial cohort, however, didn't get back out. Now they start becoming your chronic population at the state mental hospitals, and people say, see, that chronic population, schizophrenia, you never get better. That's because we've lost the 2/3 that did get better and went back to sort of some sort of degree of functioning. So even at this disorder we say is the most severe, you actually see a lot of people recovering. Now you might say, listen, that's the old days, they diagnosed schizophrenia better. I mean, it's differently than that's not a group so ill. Well, we have one modern study that followed schizophrenia patients for at least 15 to 20 years, starting in 1980. And there, of the people who got off their medication, which was a fair number, almost half, of schizophrenia patients, over half were working by the end of 5 years and stayed working the next 10 years. Over 70% weren't psychotic anymore long term. There was about 25-30% that remained actively psychotic. So even with this disorder we say that is so difficult, you actually see a lot of recovery. So think about that. More than half working, 2/3 in relationships. That's a vision of, quote, psychosis/schizophrenia we've totally lost. But in fact, if we tried to flesh out the natural course of schizophrenia or first episode psychosis, you'd see a lot of recovery.
It's quite clear in the controlled studies that it's the drug that causes, for example, the gastrointestinal symptoms, the insomnia, the agitation, the sexual dysfunction that we're seeing, because there are stark differences between those patients randomly assigned to the drug and those randomly assigned to the sugar pill.
If you see a difference between the normal and the so-called ADHD kids, how do you know if you're not seeing, instead of an organic pathology, what if you're seeing the effects of drugs?
I was dead. I had no light in my eyes. I was completely sedated. All the medication that I was on sedated me to the point where I can't remember 90% of my life. And at some point, that does break a person. And getting those memories back is extremely difficult. So when they tell you you're broken, when they tell you you need to be there to be fixed, that you're going to be there for a long, long time, who the hell is going to make me think any different if I can't even remember how to smile, what it's like to really be happy? I hate it. I would love to know what it's like to be happy again.
The numbness that I felt taking the Cymbalta was really, I don't know how to really compare it to anything except maybe an alcoholic beverage. You have a stiff drink and it just kind of makes you take the edge off. But the problem is it's all the time. You can't just take the edge off when you need it. It's all the time. So you're always feeling this numbness. So if you're ever without it, your body doesn't know how to deal with things.
How do we know that the suicidal thinking and behaviors are not just part of the depression? How do we know they're really caused by the medicine? And this is a question that confused researchers and clinicians for a long time, but the randomized controlled trials help us answer that question. What the FDA did in the case of antidepressants, they said to the drug companies, we want every study you've ever done, whether it's been published or not, whether you submitted it to us or not, put all the data together in one big pile, and if we have enough subjects, we might be able to detect this signal. Gives you more, what's called power, more statistical power. So they put together maybe 7,000 patients from all these, over 30 studies into one big pool, and did the analysis, and they found out that the patients who had been randomly assigned, and it's the random assignment that helps you make this determination, the patients who had been randomly assigned to the antidepressant had a 4% rate of suicidal thinking and behavior. The patients who had been randomly assigned to the sugar pill had a 2% rate of suicidal thinking and behavior. So there was a doubling of the risk in those patients who had been randomly assigned to the drug. So here's how I've put it. The risk is low, but the stakes are high. That's 2 extra suicidal patients for every 100 patients that are treated with these medicines.
Yes, I have a friend of mine whose son was depressed. He went to the psychiatrist. He was told that he had a chemical imbalance, that it would be with him the rest of his life. That afternoon he went home. He closed the garage. He hooked up the exhaust to the window and killed himself.
One of the key statistics that I think everybody should be so seriously disturbed about is that the number 3 cause of death of young adults from age 15 to 24 is suicide.
I was first suicidal when I was 8 years old. Most of my recovery really has been emotional, which has driven everything else. It's been a journey from suicidal sadness and depression to some sort of vibrance and self-love that's healthy, not not narcissistic.
My daughter was on the edge of a cliff, so I took her to this rehab place, and they drug tested her and did a psychological panel, and they wouldn't let me take her home. They said she was suicidal.
I was 13 years old. My grandmother had just died, and I had attempted to commit suicide. For I think the second time, I can't remember. They all kind of float together.
Well, there's actually been a couple of times I tried to commit suicide. One time I took 17 Vicodins, and all I did was go to sleep and then wake up with an upset stomach, which the opiates cause you to have. And then another time I took the razor and I started slashing my wrist. I'm sitting here just cutting like this, and I'm not bleeding at all. And then I found out later from another person who is apparently crazier than I am, you actually have to cut yourself like vertically, not horizontally.
I took the low entry dose of Paxil, 20 milligrams, and I instantly felt better. But I stopped Paxil after a month because I didn't want to be taking a medicine every day. And after a month, the literature and the doctors say you're not supposed to go through withdrawal because it's only been a month. But I went through acute withdrawal. I stopped it suddenly, and it was as if I was taken over by this profound sense of agitation, physical and psychological. I remember I was just lying on the couch, I couldn't get comfortable. I ached all over. I felt like I just couldn't sit still. I wanted to jump out of my skin, and I couldn't stand stimuli. And I really felt if I didn't know what was going on, I might have wanted to just jump out a window. I was so agitated in a way I've never felt before. Luckily, I am a psychiatric nurse, and I recognize that perhaps there could be no other explanation than I shouldn't have stopped Paxil after 1 month cold turkey, that I had to taper off of it, which I did.
The way I look at medications, if I do need to go to them, I really see them in many ways as an active placebo. We know that the placebo effect is so strong in mental health issues of any kind, depression, anxiety, that it can really be 60, 70, 80, perhaps even 90% of the medication effect. So one of the things that you want to do is you want to try to amplify the placebo response as best you can. And by working with low doses, I think you can amplify the placebo effect and minimize any side effect potential.
In the case of antidepressants, the sugar pill duplicates 82% of the improvement that we see in the active drug condition. Okay? So the sugar pill does 82% as well. That little difference between the active drug and the sugar pill is not what we call clinically meaningful, not clinically significant. It would be very difficult for a clinician or a therapist to tell the difference. So that's what we're up against. And so it's confusing to people. So let's say you're a patient. You may not understand the scientific studies, right? You just may know, I took this pill and I felt better. That's my evidence that it works, right? And so what do people use for evidence to judge whether a treatment works for them? And it's usually their own personal experience, right? So it's up to the scientific studies to tease out what exactly is going on. And they're telling us that it's something psychological for the most part.
Well, just that leads you, if you're given the placebo, to have your symptoms improve week by week, just like the drug, week by week. And in many studies, the placebo beats the drug. So right there, without even talking about meditation or education or dancing or vacation or rebellion, just in a contrived little environment where you know you might be getting something that's inert, you feel better if you get it. Because even no drug whatsoever, even a placebo, in the context of a clinical trial testing a drug, basically for all the antidepressants, the placebo is a little worse it's worse by generally 2 to 5 to 10% than the drug. So just a placebo is about as equivalent as the drug. So you're talking about remedies whose power is enormously exaggerated in our minds.
If you go off the medications, and it's very important to never go off these medications cold turkey, you should never just stop them one day. If you do go off them, you need to taper it down because your body has adjusted to these medications.
It's very important you don't abruptly discontinue many of these medications, okay? With particularly the antipsychotics, an abrupt withdrawal can actually kill you. With many of the psychotropic medications, if you're tapering down, there's what I'd call a withdrawal effect, which means, for example, if you're tapering off an antidepressant, you may be plunging into profound depression, and you need to be aware of this as biochemical in nature. And in many cases, doctors will not recognize them as biochemical effects. They'll convey the message that, yes, your symptoms are coming back. This means the illness is back. This means you need to raise the meds.
I think one of the real big problems we have in this is this. Historically, so people get put on the medications. This goes back to the 60s and all. And they don't really know much at that time about how the medications are acting on the brain. So then they would run these studies where people who were good responders, half they would abruptly withdraw from the medication and half they would keep on the drug. And those abruptly withdrawn would suffer symptoms with great regularity, okay? They would relapse. So that was seen as, see, this is why you need to be on the drugs long term, because you go off and you have all this flare-up of symptoms. But now we know it's not that simple thing. It's not just the return of the, quote, disease. In fact, a lot of what you're seeing, in some ways it may be all of what you're seeing, has to do with going off the meds, drug withdrawal problems.
What is the right protocol for medication tapering? What should be the right things to do when you have a diagnosis of schizophrenia? How do you taper medications? What if you've been diagnosed with depression? How do you taper medications? And this isn't about anti-medication at all. In fact, it's about talking to our trained doctors, our trained professionals, about what is the best use of medication, what are all the other holistic things that we ought to be using.
Currently, I'm not on medication. I am very proud of myself that I was able to taper off Zoloft after 15 years. 4 months ago, so I've been medication-free for 4 months, and it's been very, very difficult. I got off Zoloft by tapering down 2 milligrams a month in my dosage using a liquid concentrate. I needed to go that slowly, and for the first week, or 2 weeks actually, after I would lower the dose by 2 milligrams, I would definitely have extreme irritability. I'd become much more cranky and difficult to live with and dysphoric and very, very irritable was the most problematic withdrawal symptom that I had. Muscle aches. And then after 2 weeks, I'd start to feel a little more normalized, and then 2 weeks later, I'd drop it again and go through it again, and that's when it took me a year and a half to taper off.
Within the profession, like they often talk like 2 weeks is gradual withdrawal, and then you go talk to people who've done it, it's like 6 months, 9 months, a year, 2 years, 3 years. There's such a disconnect between what the doctors think is gradual withdrawal and people who have done it successfully called gradual withdrawal. And oddly enough, some of the best advice for figuring out how to do it comes from those who've done it. It doesn't come from the medical establishment. It comes from people who've done it.
I had tried to get off of Cymbalta a couple of times and went back on it because it's a pretty dramatic change. The deciding factor for me was when I was on vacation with my family and I forgot my medication. And within a day, I really became a different person. I was very angry. I would get mad at my kids for really nothing, things that normally wouldn't bother anybody. But really, I was very angry. So I knew that I needed to make a change. But there really was no protocol as to how to get off of Cymbalta. I did some research online. I called my doctor. My doctor told me that there was no set weaning off schedule from the pharmaceutical company and that I should just quit taking it. Well, the first thing I did was I opened up a pill and I counted how many granules were inside to try and decide how to make the pill less potent, because there wasn't a lower dose pill that I could take. So I had to make my own lower dose pill. So my husband came up with a little measuring scoop of how much of the medicine was 1/3, and we decided that I would start by reducing the medication by 1/3. So I took 2/3 of a pill every day for 4 weeks, and then went down to 2/3 of a pill every other day. Then I went to 1/3 of a pill daily for 1 week, and then down to 1/3 of a pill every other day for 4 weeks. Then 1/3 of a pill 2 times a week for 4 more weeks to finally be finished.
I was put on Zoloft originally for menopause. When I started going through menopause, I got very, very moody. Well, I decided after 12 years that it was time to go off of it. I was on 100 milligrams and decided to cut it back to 50 milligrams. So I just cut them in half and did that for a couple weeks, and it was fine. And then I decided to go down to 25 milligrams. And at first it was all right, and then it got really bad. I got really sick. I was nauseous, headaches. I couldn't eat, and my moods definitely changed. But I kept at it because doing the research, I knew it would take a long time. And I didn't do it with the doctor's help. I did run out of it. And I thought, okay, we've done this long enough, so I'll be able to go off of it now. And it got worse. It really, really got bad.
What they don't talk about is a whole another group of studies that have looked at long-term outcomes without the use of medications or minimal use of medications. Those studies I like to highlight to people and tell them that there are options out there. If you're going to use medications and you're going to taper off medications and you're going to have support and you're going to have structure in place and maybe some counseling and therapy as well, the recovery rates are much higher. And this has been documented for decades, for a long, long, long period of time. But it's not often told to patients. I'm not sure why. I've had conversations with different clinicians about why they don't do that. Probably because they've never seen it. I do that kind of work, and I've seen it. I know people who have been diagnosed schizophrenic. I know people who have been diagnosed bipolar, severely depressed, and suicidal, and people who have recovered.
It's a profound thing to go on a medication. That medication will change your brain, and it's not so easy. It's not so easy getting back to square one. And it's physical, it's emotional. People will describe having symptoms they've never known before, severity of symptoms. So we missee that moment. So people go off and we still see it as a return of the disorder. It's seen as a reason you have to stay on the drugs. But in fact, what you're seeing is the difficulty of coming off. And somehow that confusion needs to be cleared up. The other advice would be, hey, listen, going off is difficult. Again, it can be perilous. And actually you want to make sure if you can get some guidance, if you can get a doctor who can help you or a psychologist, someone to help that process, that's really important.
The neuroscientists tell us that our brains are not as fixed as we used to believe, and that there is some flexibility and some ability to cultivate new pathways, to come out of well-worn grooves over time if we continue to practice. The brain is like a muscle too. We can exercise it in these various ways. We can exercise this quality of awareness that allows us to encounter difficult things in different ways.
It's been understood in Western science well over a century that the brain had to change based on experience and learning, whether the learning is how to crawl when we're a little kid or do long division in grade school, or these days, just to remember what we did last summer. The brain has to change. The breaking news is not that neuroplasticity occurs, in other words, the plastic capacity of the brain to change itself, but rather how and how extensively mental activity is changing neural structure. It's an interesting thing where the science is actually probably 10 to 20 years ahead of the culture itself in terms of realizing the real possibilities here of gradually changing your brain for the better. For me, one of the most fundamental forms of self-reliance and autonomy and being in charge of your own life is to take responsibility for the most important organ in your body, the 3 pounds of tofu-like tissue, sitting inside the coconut. And it's when we do that that we wrap our arms around our life and can actually guide it to a better place.
But what happened about 15 years ago or so is that we came to understand that new neurons can be born in adults, that neurogenesis is possible throughout our lives. And that was a very, very exciting possibility. Because what that tells us is that there's hope, that essentially you can grow the brain no matter what age you are. And if you can grow the brain and have new neurons developing, you might be able to actually solve the problem of this downward decline. You might be able to have those new neurons connect to existing neurons so that there's stronger functioning in different parts of the brain. And that gives a lot of hope.
It took a genius probably to invent the game of chess, but once the game of chess has been invented, even a child can play it. So once the technique of getting out of depression by understanding the neuroplasticity of the brain means that when you repetitively think a thought, it becomes a neural pattern, a stronger neural pattern in your brain. So once you know all these things and they're put down where you can easily see the logic of how they work, anybody can get out of depression. Anybody.
The way I like to define mindfulness is that it's moment-to-moment, non-judgmental awareness. And I kind of like to break that down a little bit. So the moment-by-moment piece is that, while it sounds a bit cliche, moment by moment, moments are all we have. This moment right here is the only one in which we can do anything, accomplish anything, plan anything, remember anything is in this moment. But we often find ourselves off in other moments. So the moment-to-moment, the non-judgmental piece is to be able to bring a certain degree of kindness and compassion and patience to our own experience, and to let go of judging an experience as bad or good, but allowing the experience to be what it is without the judgment.
Well, I was introduced to the practice of mindfulness through my treatment facility. The practitioner who taught the class, she was just telling us it's really a practice of doing nothing, of just slowing down, being with yourself in that moment, feeling the moment, understanding that your feet are on the ground, understanding that the chair is holding you up. Just take a minute. And that sounds kind of mundane and easy, but it is not, especially for people who suffer with ADHD. Because, your mind is racing. And I would be in the moment and in the future and in the past and in the present, and I put them all together in a minute. But mindfulness made me break it down, say, hold up. The future's not here. The past is gone. And you're sitting right on the lap of the present. And all of us stayed with it and kept coming back to the class. And we all eventually was able to just kind of stop our minds from racing so much you know, and then bombarding us with too many thoughts. We loved it. We loved it.
So it's interesting to consider our approach to thinking in Western culture. There's a taken for grantedness about thinking, that somehow it represents reality. And that's not true. That's not true at all. So one of the things that's useful about mindfulness practice is it gives us an actual method for observing thought as an event, and not in terms of the narrative content. We don't really get it that life at times is really hard. And just because you're in pain or suffering doesn't mean that there's anything wrong. It's just part of being a human being. Often what happens in psychiatric problems is we react against life's normative pain and suffering, try to push it away or get rid of it, and then the emotional problem actually is the avoidance itself, is the pushing away.
I think the easiest way to slow down is the breath. It is our most powerful source that we have, because you're breathing right now. You have to breathe. You're always breathing, and it's something we're often not even aware of. And yet the more we can connect to our breath, and even one long, slow, deep breath before you respond to your child, even one, it can take 10 seconds, which I know we all have 10 seconds. Fine, we don't have half an hour to meditate, or, life is crazy. And trust me, a parent of 2 small children and, a working psychologist, it is, and it's hard, but 10 seconds we have. And if we can, the moment we begin to notice in our bodies that we feel activated, or our voice rises, or our posture rises, and we start to react, to just take a moment, take that deep breath, and move from that place, and everything changes.
She, made us understand that how precious our breath was, because we take breathing for granted. We're alive, okay, yeah, we're breathing. But she would talk about that breath. And staying with your breath and feeling your breath. How your lungs fill up when you inhale. And she was like, feel the warm wind coming out of your mouth as you exhale. It was like, okay, yeah, all right. And so she really emphasized our appreciation of our own breath. Appreciate your life. Made us appreciate our life more, because we take it for granted.
So you pull out a snow globe and you say, okay, let's take a look at the snow globe, and you turn it over and everybody looks at the snow globe and you watch the snow settle. And while that snow is settling, you say, feel your breathing. Don't think about it, but feel your breathing. And what will happen is the body will start to regulate. The breath awareness will start to regulate the body. It quiets down that emotional part of the brain. But when you're talking to kids, this works. The problem-solving part of the brain, the emotional part of the brain. So what happens is, if there's a lot of emotions getting upset, the emotional part of the brain gets really, really noisy. And when the emotional part of the brain is really, really noisy, the problem-solving part of the brain can't do the work. Mindfulness moves brain activity from this emotional part of the brain to the problem-solving part of the brain, allowing this to quiet. So that's basically what we're doing when we're shifting our awareness away from our worries to the sensation of breathing.
It's interesting how much research there is these days on mindfulness or other forms of training attention. And it demonstrates that for certainly most people, it actually gives us opportunities to change the brain for the better, just through mental activity alone, not necessarily through medication.
Many people feel their situation is hopeless, and so don't even believe that recovery is possible. And in my 10 years of working with people and especially with the very severely distressed, with all of those nasty labels, psychotic or bipolar or chronic anxiety and depression, I've found that recovery is absolutely possible. And my definition of recovery actually is going beyond simply returning to where you were when you had a break or when your distress really overwhelmed you. That recovery is not only possible, but going beyond recovery to being better than you ever thought possible and being able to live without medication and eventually without professional support is absolutely possible.
I actually had hope before I entered treatment. So let's say when I started seeing the commercials on TV, I hate to admit this, but it was probably the commercials about the medications that gave me hope. You know, it just, yeah. I'm like, oh, okay. And so they gave me hope. And with that hope, I said, okay, I got to do something. I got to find out about myself. And I entered voluntarily into a treatment situation. Not so much the medications, but I say the alternative treatment has definitely changed me. It was the alternative treatment to medications that changed me, not the medications.
As a psychiatric nurse, had I not had hope, I would not have been able to do the job for 30-something years. Hope was easier to maintain in working with patients because people get better. People do get better. There is hope, and people are always surprising you, and I believe everyone can recover. I could not have done that work without believing every single person I worked with could recover.
If you're depressed, there's always hope. So don't go into your depression, head for some kind of hope. And when you're depressed, don't disengage from life. Head back into life. There's always something or someone or some idea that will help you, turn you in another direction. You do have to take the first step, but remember, when you take the first step, even if you stumble, even if you make a mistake, even if you fail, you have turned yourself 180 degrees around because you are now heading out of your depression instead of into it.
Growth and development can occur. They can occur in your children, no matter how much distress they suffer. And you might want to think about a search for either a clinic or individual therapists, or even non-so-called mental health professionals can be quite a bit of help. The trick is to recognize that growth and development are possible. There is no such thing as permanently stunted growth. So there is a hopeful message in that.
I have known people that have gotten better over 32 years of working in the psychiatric mental health field. These people usually have found other outlets and alternatives to help them deal with their emotional, mental, extreme distress.
The big summary statement is never view any mental health problem as permanent to the point where it determines what a person's identity is and what a person's future is going to be. I mean, we're absolutely not going to make false promises. We're not going to say that certain aspects of mental health problems are going to disappear as if they were never there. A lot of the kinds of symptoms that people deal with, and this is true of OCD, I've seen a lot of people with obsessive compulsive disorder, a lot, who they get to the point where no one could know they are managing this condition in ways that for all intents and purposes, they are normal, whatever that means.
The way that I see mental illness is it robs someone of their ability to relate. They lose their capacity to relate with their community, with their family, with their friends. They lose their personal narrative. Their consciousness is often so fractured they think that parts of it are coming to them in the form of hallucinations. So recovery is that restoration of relationship, restoration of basically the natural state of being. We all are meant to be in community, being fulfilled, not just living, but really articulating our dreams, developing it into a narrative, and moving forward with it.
We need human connections. We need each other. The idea that we can survive this life of human suffering, inevitable human suffering, by ourselves, that's an illusion. We need each other. So the implication for providers really is what Freud warned us of. Freud said, no furor sanandi, which means no rage to cure. Don't hurry to the cure. Just be with them. There's no shortcut for this. And that's really liberating for providers, because what we tell them is all you have to do is go in there and be a human being with an open heart. Isn't that beautiful? It's so simple. You don't have to go in there with a magic wand or a toolbox or a technique that you've mastered 10 years in school. All you need to do is go in there with what you already have, your heart, and open it to a person and say, I will be with you. That's a gift for both of them.